Well, hello, everyone. I'm glad to have you join us for our webinar, Implementing and Measuring Cultural Change to Achieve Quality of Life for Older Adults. My name is Lynn Mansell. I'm president of the Provincial Board of AAG. I'd like to start with the land acknowledgement. Alberta Association on Gerontology acknowledges its presence on the lands of Indigenous people across Alberta. We are committed to ongoing dialogue and shared learning to achieve healthy aging and quality of life for older Albertans. And just before we get started, we wanted to give you the heads up about our next Futures Policy Forum webinar on October the 13th. And it will be focused on enhancing community capacity and transforming home care and community senior services with a great list of speakers for you to enjoy. Next, I'd like to introduce Kim O'Brien, who is President and CEO of United Active Living, our feature platinum sponsor for today. Over to you.
Great. Thank you, Lynn. Welcome, everyone. And thank you so much for inviting us to be a part of today's forum. First and foremost, we want to commend and celebrate the work of the Alberta Association on Gerontology. And thank you for providing a venue for us all to be able to gather and envision a future that where older adults can live and thrive on their terms. United Active Living, we provide seniors communities in Calgary. And when this opportunity came our way to be a part of today's webinar, we had to say yes. There's such great values alignment in terms of what you're trying to achieve and what we believe that we're able to do and provide to our residents on a daily basis. Our communities are really centered around absolutely and foremost our residents. And we're also really delighted that later on in today's webinar, you'll have a chance to meet one of our residents who's a part of our panel. It's so important for us that on a daily basis, we provide a real community for our residents to have opportunities to live and grow and learn and form relationships on their terms and live the life that they want to. We love and value the individuals that they are. And we hope that being a part of today's forum will give some insight into some of the things that we're doing. And as I said, hearing it best from one of our residents. So thank you again. We're delighted to be a part of today's forum, and we hope everybody has a really enjoyable session. And please feel free to reach out to us at any time with any questions or any more information that you'd like to have on our organization and what it is that we do. Thank you.
Thank you, Kim. The importance of quality of life in transforming senior services can't be overstated. We all use the phrase, and it increasingly guides government policy and legislation, aging research, reports, and initiatives across the spectrum of services. But how do we define, implement, measure, and report quality of life? In today's webinar, we will hear how some older adults define quality of life, share some recent research measures and public reporting, provide some examples of good practices, and seek your comments and questions. So I'll now briefly introduce all of our speakers, starting with our resident family panel. Jim Mann joins us from Vancouver. He was diagnosed with Alzheimer's in 2007 at the age of 58 and has been very active in the community, promoting the inclusion of the voices of people with lived experience in research and in policy development. He's an accomplished speaker, writer, and advisor. Among his other appointments, Jim is a member of the Research Management Committee of AgeWell, which focuses on technologies and services for healthy aging in Canada. Lisa Poole is a family care partner from Calgary and provides insights from the perspective of lived experience. Her father, John, recently deceased, lived with dementia and resided in long-term care. Lisa is involved in many organizations, including the Dementia and Alzheimer's Society of Calgary, as well as AgeWell's Older Adult and Caregiver Advisory Committee and the Dementia Advocacy Canada. Jim Dolph has been a resident at Garrison Green's United Active Living Residence in Calgary for 8 years. Jim and his late wife raised 2 children, whom he continues to find great joy in spending time with. He is very active in his community and leads a sing-along group for residents with his daughter. During his time at the residence, he transitioned a love of photography and landscapes into a love of painting, and you will find many of his art pieces throughout the halls. Jim has participated on the resident council, the food committee, and has been integral in welcoming newcomers to the community. And moving on to our keynote speakers, Dr. Tatiana Shippey is a social gerontologist with a dual PhD in sociology and gerontology. She is a tenured associate professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health. She spent 2 years living in a long-term care facility to better understand the factors that impact quality of life for older adults. Her work aims to eliminate racial and ethnic disparities in access to and use of long-term care services and supports, and also improve the quality of life for older adults. She leads multi-million-dollar projects to address equity and quality of life in long-term care. Dr. Matthias Hoban is a registered nurse and holds an undergraduate degree in nursing management and an MSc and doctoral degree in health and nursing sciences. He is an associate professor and Helen Carswell Chair in Dementia Care with the School of Health Policy and Management, York University, Toronto. His research focuses on evaluating and improving the quality of life of older adults living with dementia, as well as the health and well-being of their paid and unpaid caregivers. Dr. Sienna Casper is a certified therapeutic recreation specialist and associate professor at the University of Lethbridge in the Faculty of Health Sciences Therapeutic Recreation Program. Her areas of research include organizational behavior, empowerment, interprofessional teamwork and collaboration, quality of care, and quality of work life in dementia care. Dr. Casper has also worked as a clinician and consultant in long-term care homes in both Canada and the United States for over 20 years. So first, I'd like to turn the floor over to, the Q&A session. So please remember to place your questions and comments in the Q&A box, not the comment box, because that's how we'll know what your question is. And the Q&A session after everyone speaks will be facilitated by our webinar host, Jordana Bubar. Okay, now over to Jim Mann from Vancouver.
Thank you, Lynn. My quality of life is focused on advocacy, communication, research, writing, and governance. In many ways, I'm fortunate that my business career skills in advocacy, marketing, and communications, and my experience with my wife accompanying my mother along her journey with Alzheimer's merged with my own diagnosis of Alzheimer's. I saw the stigma of dementia through my mother's experiences and soon came to realize there was a lack of awareness of actually being able to live positively with Alzheimer's, due in part, from what I could see, to the absence of the voice of people living with a diagnosis of dementia. I was first diagnosed in February of 2007 and attended my first public policy meeting of the Alzheimer's Society of BC in November the same year. I'd retired early from my employer, did some consulting for a few years, but realized that wasn't sustainable with memory challenges, word-finding challenges in meetings, etc. So connecting with the Alzheimer's Society was going to give me, and to this day still gives me, my type of quality of life. That said, I can't stop thinking of people with dementia who have received a diagnosis of dementia and who struggle with finding their own quality of life, their purpose, their reason to get out of bed in the morning. Take my support group, for example. Some in my group, that I should note hasn't met since early 2020, no longer drove, didn't use public transit, and nor did they use a computer. In contrast to others who found their purpose and quality of life through volunteering. I feel so fortunate. Since my diagnosis, I've learned research is not just biomedical. There is psychosocial research, and that is the area of focus of research I pursue. Currently, I am co-principal investigator of a participatory action research project focused on the stigma of dementia, a co-investigator of a project in long-term care using a robot for connecting to family and friends, and through the wonders of Zoom, I'm even a co-researcher of a participatory action project in Germany. Before I was diagnosed, and definitely after, I never thought I'd be writing and co-writing peer-reviewed papers or forewords for texts. Nor did I imagine I would be the Jim in the Jim's Push for a Plan campaign the Alzheimer's Society of BC ran a few years ago that took me around the province advocating for the development of a provincial dementia strategy. While I mention these various projects and activities to illustrate my personal measurement of quality of life, I am most proud and honored to be able to be a positive, lived experience with dementia voice that I felt was missing when my mother was alive. Besides being an eye-opener for those not personally or directly impacted, I am confident knowing they have heard a voice of reassurance that a good quality of life is possible for those living with dementia. To be clear, my voice is but one voice of a person living with a diagnosis of dementia. There are many other people who also express the same or similar sentiment. Oh yes, my last point. What I do sure beats painting.
Thank you very much, Jim. Okay, over to you, Lisa.
Thanks, Lynn. Well, sort of echoing, I think, some of the points that Jim was making is that there's no one size fits all definition of quality of life, and it means something different for each individual and each family. So there are big issues like staff ratios and small issues like the right amount of sugar in a cup of coffee. These things can impact quality of life, but it's of critical importance to understand individual abilities and preferences when trying to understand quality of life. My father was in 5 different care homes, so we had the opportunity to develop some interesting perspectives on new, old, big, small care settings, and to notice how the differences impacted our quality of life. For us, quality of life includes a care home that's easy to get to. When the weather is bad or there's lots of traffic, it's extremely stressful when there's an emergency that requires you to get there as quickly as you can and you're far away. Or even if one of us wanted to go visit my father and he would be sleeping, in traffic, it could be close to an hour drive each direction, and it wasn't just easy to come back when he was awake. On the flip side, for a short time, there was a care home in the neighborhood where my parents lived that my dad lived in, and my mom could easily walk there. And what a difference that made. Within walking distance is the gold standard. Another important issue for quality of life for my family is access to the outdoors. When my father was in that small home in the residential neighborhood, he used to love to sit on the front porch and watch people go by walking their dogs or little kids across the street playing in their front yards. But no matter where he lived, we took him outside as often as we could. Even on a cold winter's day, we would put on a toque and cover him in a fleece-lined poncho and boots to keep him warm. And he loved it. And even though my father did not speak in his last few years and communicated through facial expressions, we all know that feeling when it feels good to get outside into the fresh air. And so he could show us that that was something that he really enjoyed, which gave us a lot of joy. And so this might not be a top priority for others, but it was really, really important to my father and to my family. And so it was devastating during the pandemic when he was not allowed to go outside. Consistent care assignments. I can't stress the importance of having familiar faces. people who understood the subtle nuances of my father's communication style. It brought great peace of mind to the family. People who were able to develop a personal relationship with him and with us, and who understood his personal preferences and related to him on a human level with respect and compassion, and who treated my father like an individual and not an object. As we all know, a revolving door of task-based, unfamiliar faces is not quality of life. And I think it's also important to remember it's not quality of life for the staff either. But that's another issue, and I think we might be hearing more about that later. Trust, stating the obvious. But if you do not feel like you can trust the people providing care, especially when you're not there, it's extremely stressful. We arrived once to find my father with a black eye. No one knew what happened, and there was nothing in his file. It's entirely possible that he tripped and caused it himself, but we never found out. And it caused us tremendous consternation because we didn't know how my father was being treated when we weren't there, and that was extremely stressful. And so another important measure for quality of life for us was staff with the skills and knowledge they need to do their job. Can the nicest, best meaning person providing care, but if they don't understand dementia, things can escalate very quickly in a way they're not expecting. And next thing you know, the person with dementia is in a lot of trouble and possibly even put in restraints or kicked out of their care home they're in for a situation that could have been avoided if the staff had a better understanding of dementia. So what matters to my family might not be the same measure of quality of life that other people have. And so I just really want to emphasize there's no one size fits all definition for quality of life. Thank you.
Thanks very much, Lisa. And over to you, Jim Dolph.
Hello, everybody. Thank you. My objective in this presentation is to state some of my own qualities of life and to note that most are attainable at Garrison Green. In addition, many of the same qualities are shared and pursued by other residents here. There is a broad spectrum of choice, something for each level of ability here. Attempting to assist and serve others is my personal wish. It is rewarding and a means of breaking free from my own limitations and disabilities. Like most people, I have often said, I wish I had more time, and I'll do that when I get more time. Now, I find that time is something I have an abundance of. And so to me, quality of life is being able to fill that time in ways that continue to provide purpose and direction. At Garrison Green, we have a published daily schedule of numerous activities with assistance provided where needed. By keeping the doors open to new experiences, I explore this in many ways. For example, at age 80, I started art painting for the very first time. All the assistance required at the time was provided. So now I play with colors and ideas. It's fun. Another pleasurable experience is enjoying meals. I get to choose where and with whom I eat. It's an opportunity to meet others, to make new friends on a casual basis. We elderly are often lonely. Most of us have lost family members, a spouse, or a friend, or even a son or a daughter. So I find comfort in connecting with others around me. I lead a sing-along group with my daughter, and it's less about singing than it is about getting people out of their rooms, having a good time, and keeping things positive. We have fun, and who cares if we can sing? Of course, quality of life comes with feeling good at the same time, freedom from pain as much as possible, and staying on top of feeling good is important to me. I have access to the assistance of nurses, a balanced diet, exercise classes, and walks in our adjoining residential neighborhood. Thank you for listening.
Thanks very much, Jim. And now we're going to turn to our keynote speakers. First, Dr. Tatiana Shippey, University of Minnesota.
Thank you so much. How do I follow up on those absolutely inspiring and amazing stories? And I think Jordana will share my slides here. Well, I am absolutely inspired. Thank you to the three of you for sharing your perspectives and your stories. And what I do, I have dedicated my career to focusing on measuring and improving quality of life, especially for nursing home residents, but really for everybody in long-term care. As Lynn shared a little bit in my introduction, I was honored to spend 2 years living in a long-term care facility now about 2 decades ago, but it is the reason why I do the work that I do, because I heard from residents who said that this really matters. So let me see, I can advance slides here. I want to make sure that I acknowledge my funding from the National Institutes of Health, in particular National Institute on Aging and National Institute on Minority Health Disparities. And I'm also tremendously grateful for my team, because this work would not be happening without an important team collaboration. So in the 12 minutes that I have with you, what I'm hoping I can share, and I'm really looking forward to your questions and comments, I want to talk a little bit about how do we actually measure quality of life? And I'll focus on nursing home settings for the purpose of this presentation, but happy to answer questions about assisted living in other settings, maybe if we have time in Q&A. I want to talk a little bit about disparities in quality of life and factors that we know are associated with better quality of life, as well as looking forward to the future, as is the focus of this forum. What are the implications for policy and future work? So to start with, we know, I will speak about United States, but I think this is pretty universally applicable, that at least in the US, nursing home quality of life and nursing home care in particular has been a persistent concern for consumers, their family members, and policymakers. When it comes to research and the metrics that are being reported, vast majority of studies have focused on quality of care. And when we think about quality of care, we think about clinical services. So for example, bed sores would be one example of those. Absolutely, clinical measures of quality matter, but as residents with whom I lived in a long-term care facility told me, they want to be thought of and treated as people first. And that's where quality of life comes in. We think of quality of life as a multi-domain measure of well-being that extends beyond just clinical indicators of care. And so it would include experiences such as Jim talked about, enjoyment of meals, relationships with others, having meaningful activities such as you starting your painting at age 80, which is amazing. So while quality of care measures, I would argue that it is quality of life that has been lacking and needs to be measured more directly. My argument that quality of life measures, and starting this work back in the early 2000s, is now supported by a variety of policy stakeholders in the US. Most recently, in April of this year, I don't know how many of you are familiar with the release of what I would say a historic report issued by our National Academies of Science, Engineering, and Medicine, or NASEM for short, that specifically focused on the national imperative to improve nursing home quality. And really, this came out from COVID, where all of a sudden the general public woke up to the fact that nursing home care in the US is really subpar, that most COVID deaths were happening in nursing homes, and that it was time to do something about nursing home care. And so in these last few years, it's been really encouraging to see Centers for Medicare and Medicaid, as well as the Institute of Medicine report from before, explicitly calling for the measurement of quality of life measures. For the NASEM report in April, they issued 7 key recommendations, and the first one of those recommendations is to measure person-reported measures of quality, such as quality of life. And I wanted to share that I'm honored to be co-leading that committee with the leaders of the Greenhouse and the Pioneer Network. We have a committee of 16 members, national stakeholders representing providers, as well as residents in long-term care, where we're hoping to now implement these recommendations from the NASEM report into practice. So this is really encouraging. It's taken so long, and finally we're seeing movement in this. What I would like to show you is how could we do this work, right? We are all acknowledging, and I think Lisa talked about how, what's important for your family maybe is not exactly the same things that are important for another family. And so that's been one of the common concerns. Well, if quality of life is a multidimensional measure of well-being, how do we actually measure it? And I would argue that Minnesota, and I was very excited to work at the University of Minnesota and choose University of Minnesota as my placement because it's been one of the 2 states in the United States that has been an example, and really nationally, in how quality of life can be measured. So in Minnesota, in 2005, our state has passed legislature that has mandated the collection of quality of life from residents in all of our Medicaid certified nursing homes in the state and has appropriated funds to do so. This really happened because of the close partnership between our state agencies and researchers and a variety of other stakeholders who pushed for this to happen. And I believe it was tremendous and really shows that this could be done for other states in the nation, as we're now looking at nationally. So this work started in 2005. And what happens is there is an outside agency that comes in and conducts about 13,000 interviews for a random sample, as I said, of residents in all nursing homes in the state. The questions that they ask have been validated and include residents with cognitive impairment, because as we know, up to half of residents in nursing homes have cognitive impairment, and absolutely their voices should be asked about their quality of life. And our work also shows that yes, they can talk about how their quality of life is going. And so then what happens, these interviews are aggregated on a facility level. And so each facility gets a score. And what I will show you here in the next slide is just a screenshot for you to see. If you went to the Minnesota Nursing Home Report Card, you would see all of the common measures of quality of care, which are important and matter. But guess which measures are most often looked at by consumers and their family members in choosing nursing homes? They want to see these measures of quality of life. And so they can compare facilities on, food, and they could look at relationships with staff, and they could look at autonomy and environment and overall satisfaction with facility. And we have seen again that these measures matter for our consumers. Our providers are behind these measures. And we have a number of quality improvement pay for performance projects that specifically also focus on improving quality of life. So facilities can get funds to improve, their environment or their privacy or food and activities, which tend to be among lower scored measures, but are so very important. So quickly here, what are some of the key predictors of quality of life? As I said, I've dedicated my career to studying quality of life. And so we know that there are resident and facility characteristics that are associated with better quality of life. In fact, Lisa talked about some of them, and Lisa, this is supported by research. I'll start by facility characteristics. We know that on average, smaller size is associated with higher quality of life for nursing home residents. We also know that a nonprofit status is associated with higher quality of life versus for-profit status. Administrator turnover has been a very consistent predictor. Higher turnover, worse quality of life. Quality of care matters too. So if people receive poor clinical quality of care, they report lower quality of life. Staff hours, absolutely important. And what my work has found that while RN care hours matter, and we usually talk about RN hours, for quality of life, activity staff hours really matter. And we've shown that improving just so many adding so many activity hours per resident day results in tangible improvements in quality of life, especially satisfaction with activities. And payment source, facilities that have higher proportion of Medicaid tend to have lower scores on quality of life, and that's associated with access to resources. But resident characteristics influence quality of life as well. So we know people who have limitations in activities of daily living might report lower quality of life if their facility environment is not supportive. Having diagnoses of dementia, Alzheimer's disease and related dementias in our work, those individuals report lower quality of life, which right away shows the need for more policy and clinical support to improve their quality of life, as well as those who have diagnoses of anxiety, mood disorders, and diagnosis of mental illness. Finally, we don't have a lot of time to talk about it, but I wanted to share that our work finds that there are persistent and significant disparities in quality of life for people from minoritized racial ethnic backgrounds. In particular, we find lowest quality of life scores for Black and Indigenous residents when compared to white residents. I can talk about many reasons for that if we have time. And we also find that facilities that have a higher proportion of minoritized residents have on average lower quality of life scores, which calls for policy change. And so finally, to conclude, Where do we go from here? I think our work in Minnesota shows that absolutely it is possible to measure resident reported quality of life scores, and that our measures must evolve to center on the experiences and voices of residents. We've also developed measures of family satisfaction, which are very important, and separate measures of satisfaction for short stay, post-acute care residents, which have very different priorities than long stay residents. I think it is vital that we focus on addressing disparities and striving for equity as we focus on improving quality of life for everybody, the need for reliable and valid data, and finally, really the need for partnerships. When we think about long-term care facilities, we should not think of them as existing in a vacuum, but how is it that we can partner more with our community organizations to ensure that there is a joint effort on improving quality of life for all the residents, especially for facilities that have fewer resources to do so. Thank you so much.
Thanks very much, Tatiana. And now we'll turn to Dr. Matthias Hoban, York University of Toronto. I was going to say University of Alberta there for a moment, Matthias, but
yeah, that would have been true until the 1st of July. So thank you very much for the opportunity to give a keynote on this webinar. And similar to Dr. Shippe, my passion is focused on improving the quality of life of older adults across settings, but of course, it is a big concern in institutional settings, in long-term care and in assisted living. This first slide is just to summarize actually what gives me joy, what helps me achieve good quality of life. And you may find 3 themes in there: being active, especially outdoors; food, especially chocolate and coffee. If you supply those and family plays a role as well, then I'm pretty okay, I would say. So we've heard from previous speakers that quality of life is highly individual. And I think it's probably helpful to specify that what is highly individual is actually what makes me feel good. I think we can agree that how to notice whether somebody feels good or not, that is something that is relatively agreeable, or that can be standardized. Otherwise, it wouldn't be possible at all to measure quality of life, but we can do it, right? So I want to acknowledge my funders. I've received funding from the Alzheimer's Society of Canada, from CIHR. TREC has been involved in that research as well. My previous faculty also supported some of the research. And I also want to acknowledge all the participating facilities, care staff, residents, my project staff, without whom I couldn't have done any of that research, and the students, the whole team. So I'm going to go over that really, really quickly because Dr. Shippe mentioned most of that. But I think one thing I want to really, really highlight is that what we routinely measure, such as these objective indicators of good care, such as the rate of falls, the rate of pain, all these different things, they are highly important. But the thing is that quality used to be defined, or still is to a large extent, as like the absence of these negative things. But that's just not sufficient. That's just not enough. Of course, I will have a terribly hard time having good quality of life if I have daily or excruciating pain. But just taking away that pain doesn't guarantee that I feel good about my life. There is many more things that need to happen there. And that is something that's a big gap in the system. And the Canadian provinces are not as far ahead as Minnesota, as Dr. Shippe just described. We're not routinely measuring these issues at all. So in 2019, we had a big policy forum that included people from the government, from the healthcare system, from the long-term care sector, also researchers and people with lived experience, just to discuss how can we routinely measure quality of life across nursing homes, especially given all the different challenges, right? Like if somebody's really, really very advanced cognitively impaired, they may not be able to verbally communicate. They may not even have family to give proxy assessments. Many of the tools are measuring they're more functional measures in disguise rather than actual quality of life measures, and so on and so on. So there's resource constraints. I'm not going to go into that into detail, but what the team decided at the time is that one tool that we wanted to understand in more detail and that really looked promising to us was the DEMQual suite of instruments. The DEMQual was developed by a team in the UK around Shubhi Banerjee, who was also part of that research. And they developed, first of all, two different versions. One that's a self-report version, so an individual with dementia would answer the questions. And there is a proxy version, so in case the individual with dementia can't self-report anymore, you can ask a family or friend proxy. But in addition to that, the team also developed a version that can be completed by care staff who know the resident really well. And this is important because we think there is a high proportion of residents in nursing homes who are very advanced, cognitively impaired, and who don't have family and friends. And we want to know about their quality of life as well. So having an additional version that can involve care staff in the assessment of quality of life of those who don't have family proxies and who can't verbally communicate anymore was something that we really were interested in. And this is why we looked into that specific tool. First of all, that tool measures what we think really matters for quality of life very deeply. It's about the residents' feelings, and it's also about the residents' worries, not so much about functional issues, because the RAI measures, like the routinely collected data measures, function quite well. We don't need any additional tool to do that. The DEMQual tool also provides quite some robust psychometric properties. It has proven in preliminary studies to be feasible and acceptable. And as I said, it's the only tool that can be completed by the direct care workers who provide 90% of the care for the residents. So what we wanted to know is whether that specific tool can be feasibly applied in the Canadian context as well. And what we found in a smaller study, oh, that was too far, was that it is highly feasible. A care aide can complete that tool within less than 5 minutes if they know the resident well. That means they have to have cared for the resident in at least during at least 3 or 4 days in the last week, and ideally over multiple shifts. And questions such as, has the resident been tearful? Have they cried a lot? Have they been worried? Have they been angry? Things like that. That is something that a care aide can observe and validly answer. The tool was, in our preliminary study, reliable and provided good variation across scores, and the participants, i.e. the care aides and the managers who helped us with that study, found it feasible and valuable to use that tool and relevant for their practice. We also did cognitive interviews with the care aides to understand how they interpret the items and if there were some glitches. And we found a couple of challenging items, especially in care aides whose first language wasn't English. So there is some room for improvement that the tool needs, maybe by clarifying some of the instructions or looking into the wording. This slide, unfortunately, doesn't come over very well. This was just to demonstrate how the tool can be used in a couple of exemplary measures, but Zoom somehow messes up my formatting here. This is just to demonstrate that the scores can be visualized in an accessible way, so a facility can compare their own scores to other facilities and change over time, again, compared to other facilities. That score, that slide here, thankfully wasn't messed up. That's much more important. This is an example of how we can present the individual resident profiles of quality of life. So each ID up here would be a resident in a facility. So the facility could replace that by the resident's name. These are 3 measures over time. And each of the rows is basically one of the items has the resident been cheerful, worried, anxious, frustrated, full of energy, and so on. And the scores all range from 1 to 4, and higher is better. So if the resident is yellow or green in that area, it's a positive outcome. And if it's orange or red, it's a reason for concern. And facilities are encouraged to think about possible reasons for why the resident has been sad or worried and what could be done about that. So this is due to the color coding and due to the item by item level. This is something that turned out to be really powerful when we discussed resident situations with care aides, just feeding back the quality of life scores to the teams again and trying to get to the bottom of, okay, now what can we do for Mrs. Jones to improve her happiness and well-being? In addition to that, we used the DEMQual in another study that assessed the impact of COVID-19. And in that bigger study, we had some pre-COVID data and then collected in an additional, or in these same facilities in Alberta, follow-up data that was done in the TREC COVID-19 impact study. Unfortunately, we did not have quality of life pre-COVID data, so it's a cross-sectional study at the time of COVID-19, but we still decided to add a couple of quality of life assessments in nursing homes that had capacity to support us with that. And we also linked these quality of life assessments with the residents' clinical data. One important finding is that all the predictors, all the factors associated with quality of life that we know from the literature, that also Dr. Shippey reported on as well, were associated with quality of life exactly as expected and highly significantly, which speaks to the validity of the tool that we used. I want to point out just a selected set of outcomes. So we see here, for example, that it's at the very bottom, the recent COVID-19 outbreak, i.e. within the last 2 weeks before we collected the quality of life data, decreased quality of life substantially among residents. A facility not having access to a geriatrician or a geriatric psychiatrist also decreased quality of life. The proportion of care aides who were highly emotionally exhausted also substantially impacted and decreased the residents' quality of life. And as Dr. Shippey reported as well, not being white, having an ethnicity other than white, also decreased quality of life. The one interesting finding that I want to conclude with is that overall cognitive impairment rather positively than negatively impacted quality of life. And in many of the studies that we see, it's highly heterogeneous. Cognition doesn't matter too much, which just shows us that people, even with advanced cognitive impairment, can have good quality of life. But cognitive decline in the last 90 days, that was the outcome that decreased a resident's quality of life. So if there is a significant change, then quality of life is affected. But probably over time and with the right context, conditions, and support, a resident, even with severe cognitive impairment, can adapt and adjust and then experience good quality of life. So this is just a quick summary of a study that is a follow-up here. I received funding from CIHR for a big study in which we will assess quality of life across 4,000 residents in 5 Canadian provinces. Again, link it to the clinical data and also collect a couple of other social indicators of quality of life to assess certain associations that in Canada never have been assessed comprehensively. It's quite an exciting study that I'm in the process of launching. And I've almost overcome the barriers of cross-provincial ethics approvals. We're almost there, so the study is about to launch pretty soon. So with that, I pass it back to Lynn, and thank you very much.
Okay, thank you. And don't forget, if you have questions for any of the speakers that we've heard from, you can start putting them in the Q&A box. So our last speaker today is Sienna Casper, Dr. Sienna Casper from University of Lethbridge.
Thank you. Wow, I just feel so honored to be able to be a part of this panel, this entire discussion. I have to say, as a recreation therapist, so many things that have been stated are just like music to my ears. They warm my heart. And, you know, the pandemic has been just so challenging in so many ways. And I absolutely honor that. And I also, though, do believe that one of the positive outcomes of it, though, is this increased focus on quality of life. And those of us who have been deeply involved in the continuing care sector long before the pandemic hit have known this. And so to actually see this shift to me is just exciting, and it just feels so very important. So I'm here to present really about, okay, so we know now, it was widely recognized that quality of life is really important, but how do we actually turn this desire to improve quality of life from rhetoric into reality? And I'd like to share kind of 5 key findings that I've learned from well over a decade of research on what are some important factors that can either enable it or also, I would say, impede this really laudable goal of changing our focus and also improving our care practices and even what our focus is on in improving both quality of care, as Matthias stated, but also really increasing our emphasis on quality of life. I need to state right up front, though, that my research is really based on the belief that improving the provision of person-centered and relational care is one of the most effective ways in improving quality of life of care recipients. And so when I'm speaking of person-centered care, what I'm really focusing on is the provision of care that respects and prioritizes the care recipient's values, preferences, and needs. And that's been a common theme throughout every single one of those of us who have been speaking. And so again, I just feel so honored and also inspired and excited about being a part of this particular conversation. So here, I'm going to begin with my key finding number one, because I have less than 10 minutes to share, key findings of over 10 years of research. Key finding number one is that educational interventions alone are largely ineffective in producing changes to care practices and care routines in long-term care settings. And we've known this, and yet we continue to try to use education as the primary means within which we produce change. And when we're trying to make this shift from a really kind of deeply entrenched focus on quality of care, it's what we've measured, it's therefore what we've valued, to really moving towards quality of life, just teaching people about this, going in and telling care staff we need to have more focused on person-centered care is not going to be effective in producing those changes. Instead, we have to look at what are the enabling and reinforcing factors that can support this new way of being to actually be realized and actualized in the everyday care practices. And what is really important to me in my research has shown that if we provide education and services on best practices in person-centered care to care staff, but we don't ensure that they can take that new information and they can apply it in their day-to-day care practices, not only does care not change and routines not change, but we can actually increase care staff's experience of moral distress by doing that. So there are many, many reasons why we've got to shift from our traditional efforts to trying to improve quality of care, and also we cannot use them when we're trying to also increase and improve quality of life. My key finding number two is that the quality of workplace relationships has a direct and meaningful influence on the care aid's ability to provide person-centered care. So this really goes back to, again, that common theme of you need to know that quality of life is different and individualized for every person. And so if we're going to be able to enhance quality of life and address quality of life, we need to know who these people are. We need to know what their values are, their preferences are, and their needs. And care aides typically learn this by developing relationships with the residents and the individuals who are in their care, the care recipients. And what I've learned is that they don't write this information down. They learn it, they store it in their minds and in their hearts. And if they're going to share this really important information with their colleagues, with other care aides, so that everyone can have access to this really important individualized care information, about the care recipient's values, their needs, their preferences. If they share it orally. They share it with each other because they know one another well, and they care about each other, and they also are able to develop the sharing of information through relationships. And this quote really kind of summarizes this statement. If two girls don't like each other, one great tip that one had that could save us all time and injury doesn't get shared. So if there's a toxic workplace environment, they don't share this information with each other. So that's one of the many reasons why the workplace relationships can have a direct and meaningful impact on the quality of care and therefore quality of life as well for residents who are living in continuing care settings. The next key finding is that the presence of leaders who demonstrate respect, show appreciation, and give recognition and actively respond to the needs and concerns of staff is essential to any initiative aimed at producing changes in care practice. So I developed kind of a model, a visual representation of my findings around how important leadership is within care, continuing care settings in really impacting quality of life and quality of care within those environments. So I found that managers and team leaders who demonstrated respect, recognition, responsiveness really helped to produce what I refer to as organizational trust. This is when care aides really believe that they are cared about and trust that they are cared about as people too within the care home. They also feel that they can trust what management says and does. When this trust is present, that was really essential to supporting this reciprocity between the care teams. In other words, where care staff took care of each other as well as taking care of the residents. And this sense of we are a family here and we take care of each other was really prevalent and evident within the culture of the care home. And when that reciprocity was there, that really enabled this increased resilience of the care staff as they faced common workplace adversities that we see frequently within long-term care and continuing care settings. And these include things like being resilient in the face of dealing with scarce resources like staffing levels and supplies, even access to supplies on the weekends. What happens to linens on the weekends? As well as their resilience in managing safety issues with residents who may be resistant to care, as well as heavy residents where you require more than one staff member to be able to lift and transfer. And of course, support when they are grieving when residents pass away or die. When there is this resilience, it absolutely has a huge impact on the quality of their work life, which absolutely directly influences the quality of care, and I would say the quality of life of the residents whom they are there to serve. My fourth key finding is that successful culture change is best achieved through the development of mutually agreed upon culture change initiatives between staff and managers, rather than attempting to implement a predefined culture change model. And this is because I believe then you are using grassroots. You're actually enabling and supporting change from the bottom up. And I think it's essential for that change to be successful. My fifth finding is that when you galvanize a care team by empowering them through the cultivation of leadership, teamwork, and collaborative decision-making, they can accomplish just about anything. And this was demonstrated in a study that I engaged in that was then replicated and then replicated again, where we worked to enhance the quality of the mealtime experience for residents. And here, and I again, like the synergies and the common threads with all of these presentations are really inspiring and exciting to me. We were able to really transform the mealtime experience. And this was a participatory action research. And we went from in a care home where residents were told where to sit 100% of the time to very rarely having that happen. Clothing protectors being put on without asking 100% of the time, down to, again, very infrequently. Also giving residents consistently choices around their beverages and also their meals, like what they wanted to eat. We weren't able to move the bar very much in our first study on distributing medications in a disruptive manner. That's specifically giving medications that are crushed to residents during mealtimes. I can't think of a better way to ruin a mealtime than that. But in the follow-up study where we replicated this, we were able to actually stop that practice completely in the care home. We also increased residents in being included in the staff conversation, socialization, and this was huge. Getting staff to sit down with the residents and socialize with them and really develop relationships with them during the meal times, and then also enabling the residents to help with mealtime tasks. All of this happened from a grassroots change initiative where staff actually selected making each of these changes and then ensuring that they were sustainable. That was done by implementing this model that I developed called the FASI model. And because of the successes that we saw in this, I really decided that it's important for anyone and everyone to have access to this resource. So if you want to learn more about the FASI model, want to be able to take it into your care homes, all of the information, the training, the resources are available free of charge to anyone, and you can find that information here at the relationalcare.ca website. We're hoping that as many people access it as possible, and that it may be able to help you and your organization really enhance person-centered relational care and increase quality of life. And I'm just going to conclude by saying all of my research, all of my life experiences really affirms that quality of life is often associated to relationships and connection. And so I want to just close out my brief presentation with this wonderful quote by one of my idols, Brené Brown. And she says, I define connection as the energy that exists between people when they feel seen, heard, and valued, when they can give and receive without judgment, and when they derive sustenance and strength from the relationship. And I believe that if we're wanting to look at changing the culture of care in continuing care settings that really enhances and values quality of life, that this is going to need to be at the foundation of all of that. So thank you.
Thanks very much, Sienna. Now we're going to turn to questions and answers, so please put them in the Q&A box. We do have some, so I'm going to ask Jordana to pose the questions to some or all of our speakers.
Thank you, Lynn. Please put all of your questions in the Q&A box at the bottom of your Zoom screen. We will try to get to as many as we possibly can. The first question is from Judy. Could you please connect the dots between these excellent presentations and the concept of measuring cultural change? I will open this to the floor.
Lynn, do you want individual presenters to do it, or do you want to provide your vision for how this all ties together? I don't know who you want to respond.
I think Judy's asking how when we talked about measuring cultural change in order to improve quality of life, how do we change the culture? I think Sienna spoke to some of it from the staff point of view, so maybe something from Sienna and maybe from you, Tatiana, if you'd like to start.
Looks like Dr. Matthias is ready to start.
Oh, good. Oh, there he's got his hand up.
Yeah, I'm just thinking about some of the experiences I had in the study that I just presented on. Well, one thing that has to do with cultural change is that just by solely involving the direct care staff, care aides, into even asking the question, how is the resident actually doing? How have they been sad or not in the last 7 days? That can create quite the shift already. Like each individual care aide may think about that, but the team systematically thinking about that and discussing these things is actually quite the shift. So this is where the cultural change comes into play. Right now, everybody's focused on somehow completing the RI. Have they fallen? Do they have a pressure ulcer? Were they transferred to the hospital? All important things, but that's not getting at what we just discussed is quality of life. And the unique domain of those direct care workers usually is very close to what is quality of life. They have that knowledge. They know what helps the resident feel happier, what makes them tick, what their habits are, and so on. It's just not systematically leveraged in these facilities. So for example, when the nurse completes the RI, very often the care aide is asked in the 7 days before the RI is completed in that so-called observation period to complete a tracking sheet. And what's that tracking sheet including? Do they get daily brushing of teeth? Do they get washed and dressed properly? And that's about it. So the vision here was, and we discussed that with our stakeholders, whether including a couple of these questions or even all of them that are in the DemQual in these tracking sheets. So care aides are actually pointed to the question, is the resident sad or happy, rather than are they clean and dressed? That's a culture change, quite a bit actually. And I think that's something that you mentioned as well, Tatiana, and Sienna, you were quite strongly focusing on that too, on these kinds of things.
Since this is measurement, I'll just jump in and say, I think that it's really important to gather that information, but I also have found that if we're gathering information from the care aides who who are the eyes and the hands and they do know. We need to loop back to them and tell them what's happening as a result of that information being gathered. So all too often, we ask them to fill out these flowcharts. The carries, when I did my research, they had no idea that that data was actually impacting care plans. They didn't have access to the care plans. So if we're going to be, I think that's also, I'm just going to throw that out there, but I'm not the measurement guru. You guys are, so I will now lower my hand, and please, Tatiana.
No, I am agreeing with what you shared, as well as Dr. Hoban. I was trying to put a link in Q&A, but I'm having trouble doing so, where I have published some research with my colleagues on assessing different types of culture change, right? Culture change is a broad effort to transform long-term care into being impersonal, but to being person-centered. So to me, that's the connection, right? Like culture change means we want long-term care to be centering on the experiences and voices of our residents. And so how do we do that? I think collecting measures of quality of life is just one way to do so, but we've actually done a study here in Minnesota where we wanted to see how different types of culture change and really different places could be doing better or worse in how far along their culture change journey, because it's a continuum, how well those are actually associated with improved quality of life for residents. And we found that yes, culture change efforts are in general positively associated with better quality of life for their residents, but it varies on how far along the continuum the facility is, because some of the culture change is to improve residents' care, but also to empower staff, right? So I think it's also very interesting to see how these culture change efforts are relating to improvement in staff work satisfaction, so that then they could deliver better care to the residents. So I think that kind of ties with what you were saying, Dr. Hoban, as well.
Thank you. The next question is from Rachel. Is there any other free resources and or education for different levels of staff? Any other channels we could access? I will again open this to the floor.
Can we try to clarify what kind of resources you're asking for? Are you asking for training materials to help make that culture shift, or like concepts, or specifically for care staff? I'm not quite sure what you're asking about.
Thank you, Rachel. If you would like to clarify on resources, we will get back to you. The next question is from Jean. What strategies are in place to communicate these research findings with governments to advocate for system change?
Well, I know that I try to be a squeaky wheel. I don't know about specific strategies, but certainly I have been invited to present to various organizations, stakeholders. We who are researchers, anyone who will listen to us about our research, we're pretty passionate about it. You've probably noticed that we get out there and speak. And I will say that here in Alberta, my experience has been that they are quite open to hearing. They do actually bridge to us, policymakers do. And things like this organization also produces this really important bridge. And that's been my experience here.
Yeah, I was going to share from our experience in Minnesota. Yes, as researchers, I believe that, at least for me, it is very important that we invest in dissemination of our work, right? Not just through academic publications, which most people don't read, but actually, engaging variety of diverse stakeholders. So I would say, the model that we have in Minnesota, I think is something that's feasible and possible. I saw somebody had a question in chat about that. How do we create better partnerships between researchers and our state agencies? And so maybe, in our case, that means that we have contracts that we do with no indirects for our state state agencies so that they know we are land grant university, they know they can come to us, but also, through creation of various, I think, stakeholder empowered groups. We have a group called Minnesota Leadership Council on Aging. It's a council that brings providers, consumers, nonprofit organizations together as a nonprofit that kind of has the power then to have the ear of our policy and state stakeholders as well. So they will host researchers like me and to share my research findings, and they will kind of serve as a liaison to bring in other stakeholders. We also have various consumer groups like Minnesota Diverse Elders Coalition, which is primarily all older adults, many of whom live in long-term care, but also community settings. And so I really think we need everybody at the table to make sure that these results can, this kind of work can be elevated to the degree that it should. I see Lynn has her hand up.
Oh, just to put in a little bit of a plug for Alberta Association on Gerontology. That's part of the reason why we're undertaking this Futures Transformation Project is to affect policy. And I can confirm that we have policy advocates on the line today, and on our stakeholder collaborative committee, we have government representatives, and we work in partnership with them to share what older adults, researchers, and educators are telling us. So we're kind of just in the first 6 months of this transformation project, but we are going to do it through webinars, think tanks, and culture change initiatives yet to be announced.
Thank you. We will ask one more question. We have quite a few people wondering about support for caregivers. So just generally, what support is being given to caregivers in regards to training or certification? Is there any information or research in regards to the turnover of caregivers, and how are caregivers going to work into care when aging in place in the future?
So again, I would ask for clarification. Does that refer to the care staff, to the paid caregivers, or are you asking about the family friend caregivers?
It's Lynn again. Maybe we can assume that this time it means family caregivers and the importance of family caregivers and how they can be supported to improve quality of life.
Yeah, so this is in that specific study that I presented on family caregivers we're not a part of, but in other studies that I'm doing, in other research and work that I'm doing, they're an important part. Such as, for example, in a study that specifically focused more on designated supportive living, assisted living, where we surveyed family caregivers about their experiences during COVID-19 with not being able to access their relative and provide the care they need. So the thing that stands out crystal clear is that these family caregivers need to be involved in decision-making and in the processes in these facilities. Never was that more clear than during COVID-19. But of course, that's true for like pre-COVID as well, and it has to be more true even after COVID. Such as, for example, when the lockdowns were implemented, nobody asked family caregivers how that can be done. And there was quite a divide among family caregivers too. Like some of them said they appreciated the lockdowns and keep them safe, keep us out. And others were like, no, we want to be involved. They're only safe if I'm around. And this disparity between the family caregivers, of course, tore the facilities apart as well. So I think to start with, regardless what we do, we have to have family councils. We have to involve these individuals in decision making, and we can't lock them out completely. They have to be there. Like if we are able to let care staff in and keep them safe, then there must be a way to let the family caregivers in as well and keep them quite just as safe or even safer.
I think there is, thank you for sharing that, Dr. Hoban. I agree. And I think there's so much more that could be said. And I think the most important part, and I really appreciate this question, is us first acknowledging that family caregivers are the backbone of our long-term care systems in the US and Canada alike. And that applies to people who are in long-term care facilities, family members remain engaged, but also people who receive care in a community. I didn't get a chance to talk about it during my presentation, but I saw some questions in chat about what about community settings. And I'd be happy to share, if you're interested, reach out. Right now, I have a large project that's focusing on Medicaid home and community-based settings and looking at care for people with dementia. And what we're seeing is large unmet needs for family caregivers in a variety of spaces. Many of them are talking about, greater need for supports. We know adult care has been foster homes, adult care homes in the US during COVID were shut down. Transportation is a massive issue where we need more supports, meal delivery. And so I really think that there needs to be a combination of state, federal, and other policies to better meet the needs of family caregivers, especially those who are caring for a loved one living with dementia in a community, because that's what we see as a large unmet need, at least in the work that I'm doing.
I'd like to quickly, sorry, so you go first, Sam.
Go ahead.
I just wanted to briefly follow up on that. Same as for you, Tatiana, I have done studies I'm in the process of actually launching big studies in community for exactly that reason. One thing is a lot has concentrated on long-term care, and that's important because these settings are very, very problematic and struggle with quality. But there is this aging in place movement, and I've seen in the chat that there were quite a lot of questions around that. So the program that I'm currently in the process of setting up and that comes with that new chair that I just received is really focusing on day program settings. It's really about settings in which individuals with dementia receive support and programming basically during daytimes. And that gives families some respite and hopefully, but that's something to be actually evaluated. Hopefully that delays institutionalization, that helps people to stay in place. But the question really is, what exactly do family caregivers need to support older adults to age in place? Well, because one thing is keeping people out of these institutions by increasing the admission criteria and saying we're only allowing the most complex individuals in. Well, then they grow complex somewhere, and that somewhere is in the community. And that other type of care is thought to be cheaper just because family care is unpaid care. But if then the family caregivers and the clients in the community don't receive the right supports, I don't think a lot is gained. We just don't see it quite as aggressively anymore. It's just a bit more invisible. And that's something that I hope to tap into quite substantially in my research that I'm in the process of setting up. So there is a lot of questions such as, are daycare programs indeed successful in keeping people out of institutions compared to individuals who don't receive that? Are other programs that are available as well similarly effective? How much respite do families indeed get through the supports that are available? How many of the daycare programs that are out there are actually publicly funded, and how much has to be paid by the families themselves? Because if then there is not enough public funding, then that creates a lot of disparities again. So there's questions over questions that we're going to address and that are really highly relevant in that context.
I'd just like to do a shameless perhaps plug or plea. It has taken far too long for it to be recognized that recreation therapy activity directors are not the icing on the cake in continuing care settings. We are absolutely a key ingredient of the cake, and especially when we're looking at quality of life. And but we're still we're not considered an essential service. We are, the first to get cut when cuts happen. We are, and yet we also are the ones that all the photos are of to promote the quality of life in. All the photos are always of the recreation therapy staff and residents engaging in this. So there's this kind of acknowledged, but not real acknowledged, and that's because of how deeply entrenched it has been in the medical model. I believe really strongly we have got to get recreation therapists in community so that they can go out and assist these family members, do an assessment, help the family members, because if you don't know how to engage and have that sense of meaning and purpose and adapt previous activities and to fill the individual's life with purposeful, meaningful activities that are also at the right, adapted to the right functioning level, then you're risking for boredom and loneliness. And that needs to be part of the community care. It needs to be there in the community, and we don't see it. I think we're probably sadly a long way away from that, because we're just barely finally figuring out that if you want to improve quality of life, you need to improve staffing. That's of individuals who are in these care settings where that's their primary focus. So sorry, big soapbox plug, but it's something we have to start looking at.
Thank you very much. I will pass it back to Lynn for the final question.
I just wanted, before I do that, I just wanted to know if our family resident panel has any comments, especially on the last discussion of caregivers and aging in the community. Lisa or Jim, did you want to speak about that in particular?
I'll jump in and say, I think it should be the topic of another session. Like there's a lot to say, and trying to think of one thing to say in the short time we have left, I'm not sure that, I think it's a really important topic though that requires further discussion, is all that I'll say.
Yeah, and you're absolutely right. And we have been, we are in the midst of planning for a caregiver session in January. So you'll be hearing about it as soon as the date is confirmed in the speakers. But it obviously is of great interest.
Lynn,
Go ahead.
I think that, excuse me, I think that home care is a big component of aging in place, and the effective delivery of home care and the need for the varied services from home care, and certainly from what I have heard, I guess anecdotally, is that it certainly isn't operating well. There's lots of room for improvement, especially for people with dementia, and the care provider that is coming into the home who is not even told that the person has dementia. And so the approach will be so different. All that will lead to a responsive behavior and that inevitable purple dot or whatever it is. But I was surprised in the Alzheimer's Society of Canada's release yesterday of the first report of the landmark study that actually said that care partners for people with dementia provide an average of 26 hours of caregiving a week, compared to 17 hours a week for older adults with other health issues. And they're doing it without support and without an education. They're just sort of, it's dropped on their shoulders. And for many who are older, the adjustment to even accessing support not online, but through a telephone, and the confusion that what do you want? Hit 1 or hit 2 or hit 3, hit 4. I certainly remember my mother-in-law, hanging up and calling her daughter and saying, "You do it because I can't." So I think to me, there's a big gap there that is in drastic need of addressing before we go too far down this rabbit hole.
And Jim Dolph, do you have any comments on aging in place before I ask you your quality of life question?
Who did she call on? Me?
So
Are you-
aging, Jim Dolph, yes. I was just wondering if you had a comment about how you think individuals like yourself could better stay in the community. Because you're
I like Dr. Serena Casper. I'm on your wavelength, madam. about individual loving care of a person rather than following a fixed procedure as stated by a law or a policy. How to really get to know the person. The heck with everything else. Just be a human being, even though maybe you can't help them. Get to them. I think that's good. And that's based on love. And I think love is the center of much healing and all the things we look at. Love is at the center, will do a lot of things. But I had one thought here I'd like to mention. One of the, we as seniors are used to helping others, being grandparents, helping others. Now, in this procedure today, we the seniors are getting all the help. It's imbalanced. We the seniors want to help others. And the more we can help others, the more we get healed. So I would love to see seniors helping juniors, because it's the juniors and their research and their electrical knowledge, computers, that are going to save this world in terms, I think, of climate change, shortage of water, many things like that. I think we seniors would love to get in there and help the juniors. I'm trying to, but so far haven't succeeded. I think that's a consideration, whether you agree or not. I believe that.
Thank you, Jim. Yeah, very inspiring. I'm going to just, we're going to wrap up our session in 5 minutes or so. But I'm going to go back to our keynotes first and ask each one of you, what in your mind, this is quality of life, what in your mind is the number one change that could be made as a priority, say in the next year or two? What can, and by whom? So you can choose at the policy level or at the program level. Dr. Shippey, did you want to go first?
Yeah, I think one change that could happen is that we start consistently measuring quality of life from the perspective of the resident and reporting it. If we measure it, then it matters. Obviously, once we report it, then I want to see initiatives like pay for performance and others that target areas of quality of life that are lacking. I'd love to see all states in the US report quality of life measures for all of their nursing home residents.
Thank you. Dr. Hoban, did you want to go next?
Right. Basically the same answer. Yes, routinely and regularly measuring it in a practical way. But going back to what Dr. Kasper said before, also then feeding it back and making something with the data instead of just measuring. And also public reporting is important, but it can't be all of it, because then it's there is a tendency to use it as a stick, and facilities then try to play the system and try to somehow muddle through and be paper compliant. There needs to be what the webinar is titled as, there needs to be a culture change, and that involves including the perspectives of everybody. That's the individuals in need of care, that's the care staff, that's the families. They all, that it needs to be a measurement, feedback, and actually change package basically that is implemented. And I do think that a practical tool as the one that I presented, or some others that are out there as well, are a good start to think about.
I would echo what they both said, absolutely. And I would just add one more thing and say, once you have this information, how you create the solutions has to be done, not from a top-down expert. The experts are the people that are there doing the work every day. They are the ones that will know how to best make changes that are actually sustainable and feasible, and that absolutely family members need to be part of that team in figuring out what to do in response to this. They need to be equal members on the team, and any residents who want to be a part of it, like it can't be a top-down solution. We need to have the information, and then how we address it and respond to it needs to be from the bottom up. They're the experts. And I just want to say I was finally able to look into some of the Q&A, and I am sorry, I absolutely acknowledge all of my research is focused in continuing care settings, and so I am narrow in that and my knowledge. As many people who have PhD initials, we know a lot about a little thing, a little bit. So my apologies if I didn't address obviously everyone's needs here.
Thanks, Yana. And I know the research in the community with respect to quality of life is badly needed, and we hope will be funded soon. Before I wrap up, Lisa, did you have something you wanted to say about a change that would be advantageous in the near future?
Well, I think that there's obviously always little tweaks that we can make, but I really think that, especially from everything that I've learned today, I'd say that we need to look through the lens of quality of life for residents, families, and staff. And I think then that will guide the change. If we have that shift and that is our guiding principle, then we'll see which changes we need to make.
Yeah. And thanks to our two Jims, we have heard what at least you see as beneficial to your quality of life. So we really appreciate hearing from you. Is there anything that you'd like to add, Jim Mann?
I think it's too bad in many ways that you can't make this into bite-sized chunks, because I think for policymakers and everything, the action plan becomes too big, and they really don't know which one comes first, you know. But throughout meetings and so on that I've been to, in my mind, and I'll go to my grave on this, that the foundation for so much of this is addressing the issue of stigma of dementia. Because I think the stigma of dementia inhibits creativity, inhibits pursuing certain actions, and just influences the thought process on making improvements in culture change.
Thank you very much. And Jim Dolph, I know you gave us a great few comments about your perspective, but is there anything else you'd like to add?
I would like to thank everybody for giving me a better perspective on what's going on. No individual should have too much to say, but altogether we have a great working group.
Yes, thank you. And I was just about to say that. Thank you to all our speakers. I know I've learned a lot, and I've learned about many common themes from two countries and from various disciplines and from our residents and families as well. And it sounds like you're really starting to listen to each other. So that's great to hear. I'm just going to remind you again about our October 13th session, which is about supporting individuals in the community through home care and other community senior services. So I hope you'll join us for that one. And as we heard, we also are going to have a session in January about supporting family caregivers. You will receive a survey in the next few days. Not just did you like our session, but providing feedback on what you think is important and what we should address as our association and our stakeholder collaborative committee going forward. So I hope you'll fill that out for us. And thank you for your attendance and participation. It's been a great session. Our website is on the screen.